So thank you so much for giving me this opportunity. It's great to see all of you by Zoom. And what I was asked to do was talk about relapse refractory multiple myeloma. And it's always a hard act to follow Dr. Agarwal, who gave a really nice overview of what we are doing in the newly diagnosed space. So the good news in myeloma, as you all know, is we have a lot of drugs which have been approved. There's been a lot of excitement around the new drugs. And I think the most recent drug approval we have is for subcutaneous daratumumab. And we, in fact, have moved to switching our patients to subcutaneous daratumumab, which has been a real game changer in the management of myeloma. In addition, to that, we have a lot of different treatment approaches for the relapse refractory setting. And I think before you pick treatment for patients with relapse refractory myeloma, it's really important to assess the patient characteristics and try and understand the nature of the relapse, the frailty of a patient, risk assessment of the patient, and then come up with the most relevant treatment approach. This is just a list of all of the different randomized trials that you have out there. And I'm really not going to go into the details of this because all of you have seen some of the data. But the bottom line is we are using combination approaches even in the relapse setting. So triplets are being used compared to doublets unless you have a very frail patient or patient is unable to tolerate it. There's the combination of IRD, there's the combination of KRD, and we are also using drugs like pomalidomide in combination with either bortezomib or in combination with daratumumab. Most recently, we've had selinexor approved as well. And selinexor is being used in combination with selinexor has been used in combination with both bortezomib as well as in combination with carfilzomib in patients with myeloma. The daratumumab pomalidomide dexamethasone combination is FDA approved in the United States. We're using this quite commonly in second and third line treatment in our patients. And we do see a 9-month progression-free survival with this combination of about 86.3 months or so. Most recently, both at ASCO and EHA, we had the combination of carfilzomib with daratumumab, which was presented. This is the CANDOR study, which was presented. And the CANDOR study, as well as the IKEMA study, which I'll show you in a minute, shows very similar data, wherein you're seeing an overall response rate, which is quite remarkable, of 80+%, translating into a median progression-free survival, which has not yet been reached at a follow-up of about 15 months. Elo-Pom-Dex is being used. I will tell you that we don't tend to use elotuzumab as much because in the relapse refractory setting, it's really hard to find elotuzumab to be quite efficacious. This is the other study that I mentioned to you, which is the IKEMA trial, isatuximab in combination with pomalidomide and dexamethasone. Again, I'm sorry, this is the IKEMA study, isatuximab in combination with carfilzomib dexamethasone. This was largely done in the European Union and very similar to what we saw in the US with the CANDOR study with MRD negative disease in a subset of patients, translating into a nice progression-free survival benefit. We talked a little bit about selinexor in the table form, but we have selinexor now approved, and selinexor is a novel drug which is a exportin nuclear protein inhibitor. The STORM trial is what got its FDA approval, and at this year's ASCO, the Boston trial was presented, and the Boston trial actually confirmed the efficacy of selinexor in combination with bortezomib and dexamethasone in relapsed refractory myeloma. The problem with a drug like selinexor is the fact that it's not easy to tolerate. It is very hard on patients in terms of GI toxicity. We do see a lot of weight loss, a lot of nausea, and I think we're still working on trying to figure out what the best uh, treatment, what the best schedule for this Boston trial is when you combine it with bortezomib. In the Boston trial, they used 100 milligrams of selinexor, but going forward, I do think we have to decrease the dose of selinexor. And typically, at least in my clinic, I use 60 milligrams of selinexor and not any more than that, specifically when you use this in combination. Other combinations are being studied, selinexor with daratumumab, selinexor with pomalidomide, and we'll wait and see as to what the responses of these are. But the initial data looks quite encouraging, specifically the combination of selinexor with daratumumab, where you have a median progression-free survival of a little over a year. This is just a whole host of different clinical trials in the relapse refractory setting, and I've just put them in together, and you can see the different hazard ratios. All of them are effective, all of them are combinations, and depending on the nature of the relapse of a patient, you pick one or the other combination in the context of relapsed refractory myeloma. Moving on now, I do want to spend a little bit of time on what's new out there, and I think we have a lot of new and encouraging drugs available for us in the relapse refractory setting. None of these drugs are approved as yet. All of these drugs are being used in the context of clinical trials. So these are drugs which are going to come down the pike and hopefully will be accessible and available to you all very soon. The ones which I want to mention right now are cell modulatory drugs, or the new cell mods. And the one which is further most in its development with cell mods is Iberdomide. And Iberdomide is even more potent than lenalidomide and pomalidomide. And if you look at the EC50 of Iberdomide, it is several fold lower than that of both lenalidomide and pomalidomide. It binds to cereblon the same way that lenalidomide and pomalidomide do, and by doing so, it causes degradation of the transcription factors which are downstream, such as Icarus and Aiolos. Importantly, these also have immunomodulatory effects by secreting IL-2, as shown in this graph here. And the beauty of this is the efficacy of iberdomide has been shown, and it's been efficacious in patients who've had prior IMiDs. So they've been refractory to both lenalidomide and pomalidomide. And despite that, you're seeing an overall response rate of above 30% with the use of iberdomide. We have a newer drug now. It's the CellMod, which is 480. It's even more potent than iberdomide. And I think these CellMods, because they are oral drugs, they're extremely well tolerated, and they actually can be combined with some of our backbone drugs quite easily as well. So again, something which is worth looking forward to. We always worry about patients who have become refractory to lenalidomide and then pomalidomide, and the concern is always, what do you use next in terms of IMiDs? And we always found different approaches to these patients as well. Another drug which I did want to mention was venetoclax. Venetoclax, I think all of you have used in the lymphoma world, in the CLL world. We're using it in myeloma as well. It's a BCL2 inhibitor, and as all of you know, venetoclax can actually be quite effective in a subset of multiple myeloma patients who are BCL2 dependent, and that has largely been identified by patients who have the 1114 translocation. The Bellini trial was done. The Bellini trial is a trial which was comparing venetoclax with bortezomib dex and bortezomib dex and bortezomib dex plus venetoclax. Unfortunately, the Bellini trial had to be stopped early because of a survival disadvantage when they looked at all comers of patients. However, when you focus in on the patients who have the 1114 translocation, what was seen was remarkable responses in this 1114 translocated patient population. Now, this is the patient population which is BCL2 dependent. This is the patient population you're actually seeing MRD negativity. And going forward, I do think patients with the 1114 translocation have an alternative drug with venetoclax wherein it works quite well, and we did not see an overall survival disadvantage in this subset analysis of the Bellini trial. And if you look at the progression-free survival in this patient population, the median has not yet been reached in patients who have the 1114 translocation. I think the most excitement, though, in the relapse refractory setting in multiple myeloma has been around BCMA as a target. BCMA is the B cell maturation antigen, and what you have here is it's an antigen which is expressed essentially on all multiple myeloma cells. There's different ways of targeting BCMA. We have antibody drug conjugates. I'm going to show you a little bit of data with that. We have the bispecific T cell engagers, and most excitingly, we also now have cellular therapy, which is CAR T cell therapy with multiple myeloma. So starting off with the conjugate, we have belantamab mafodotin. There was an ODAC advisory committee just 2 days back, and there was an overwhelming uh, vote to get belantamab mafodotin approved in the context of multiple myeloma. The vote was 12-0 by ODAC, and this was largely based on this DREAM2 study. So belantamab is a conjugate with MMFA as the warhead. And if you look at this, the overall response rate in this patient population was about 30%, which translated into a median progression-free survival of close to about 3 or 4 months in this very refractory patient population. This is the patient population which has seen just about every treatment going forward. I think the big thing to know about belantamab mafodotin is the fact that you do get a little bit of ocular toxicity associated with this, as well as thrombocytopenia. People get corneal irritation with this, and I think we have to try and figure out how best to give this conjugated antibody. But nonetheless, very effective strategy, and it is an off-the-shelf approach. Other interesting approaches are BiTEs. BiTEs BiTEs are conjugated antibodies, and these are antibodies, again, off the shelf targeting BCMA. They also engage the T cells, activate the T cells, and can cause tumor cell kill by the activation of the T cell. This is preliminary data from the BiTE antibody, which is from BMS. You see an overall response rate once you get to the MTD of 6 to 10 milligrams of 90% with a bispecific T cell engager. And the most interesting thing here is you're seeing MRD negative disease as well as stringent complete responses in patients who get off the shelf bispecific T cell engagers. So, really extremely encouraging results. And then, most importantly, once you get to the maximum tolerated dose or the dose going forward in the phase 2 doses, this response is actually long lasting, with patients responding for up to 9 months while on treatment. We've been involved, obviously, with the CAR T cell approach, with myeloma, and the CAR T cell approach. I think the one which is further most in development is ide-cel or BB2121. We first did the phase one study. We saw 90% response rates in this, which translated into a progression-free survival of close to a year in, again, a very heavily pretreated patient population. The phase two study was presented at this year's ASCO in 128 patients. And the nice thing about this study was this was a global study, so it was not restricted to the phase one trial alone. Again, very high response rates, close to 80% plus, translating into a progression-free survival and an overall survival benefit, very similar to what we saw in our phase one clinical trial. If you look at patients who achieve a complete response, though, those patients at the target dose had a median progression free survival of 20 months in this patient population. Other CAR T cells are also being developed in myeloma. This is the Janssen product, and this is the CARTITUDE trial, where you have an overall response rate of 100%. And although the median follow-up of this is a little bit less than that of what you see with ide-cel, at least at the median of 11.5 months, 22 of the 29 patients treated on the CARTITUDE trial remain progression-free survival. Again, quite remarkable data. Similarly, the JCAR product or the EVOLVE study was presented as well. The differences here are, this is called Orvacell, and the difference here is that in the final product, you have equal numbers of CD4 and CD8 cells. And if you look at this again, response rates are extremely robust, north of 90% in all of them achieving MRD negative disease, translating into a progression-free survival, which is quite remarkable, and patients staying in remission for close to a year with this Orvacell drug product. So this is just summarizing all of these three CAR T cell products. The bottom line is all of them are very similar in terms of safety. We have seen very little in terms of toxicity from any of these products, which is quite reassuring. And overall efficacy of all of these products is extremely high, with more than 90% of patients responding. And this is translating into progression-free survivals, which in the Karma study, as I've mentioned, if you achieve a stringent CR with your CAR T cell product, you see a PFS of close to 20 months in this patient population. So I think what I have tried to show you all in these last few minutes here is we do have a lot of different approaches that you can use for the relapsed refractory multiple myeloma patients. We have several new drugs that we are excited about. Venetoclax, for example, should be considered in the 11-14 translocated patient population. There is encouraging data with Iberdomide and the newer CELMoD as well, specifically in patients who become lenalidomide and pomalidomide refractory. And BCMA is obviously a really promising target after you heard from Dr. Agarwal that we brought CD38 monoclonal antibodies in the upfront setting now. We are seeing a refractory patient population to CD38 approaches. That's a very difficult to treat approach, and using a BCMA target in that patient population, as you saw in the DREAM study, showing efficacy is really quite promising. And then the off-the-shelf approaches with the BiTEs and the other more personalized approaches with CAR T cells is resulting in quite remarkable efficacy and progression-free survivals of close to 2 years. So a lot of excitement around some of these new drugs. And with that, I think I will end. I'm hoping that you all were able to catch all of that, Dr. Bapna,
Yeah,
um,
yeah,
and I'll
absolutely.
stop there.
Yeah,
Thank you.
thank you so very much,